everybody. Bill Palma here. I wanted to create a little video for you guys to help study for those of you that are more visual learners, maybe than through lecture. This video is going to utilize 3D anatomy and physiology modeling to kind of give you a different perspective on some of the stuff that we covered in class. This is going to be one of two videos where we cover both the respiratory systems pathophysiology and also the circulatory system's pathophysiology. Remember, we need to combine those two systems together in order for good, solid perfusion to take place at the cellular level. And so understanding the components and how they work is very important. And hopefully for your visual learners, this will help out. So we're going to start this first video with the respiratory system. And we got to remember kind of from the get-go, the first thing we have to make sure we have right is the proper amount of gases that are in the ambient air that we are actually breathing in. And so just for a quick recap, as far as ambient air, we are looking at 21% oxygen in the ambient air. That's the air that you're breathing right now. Some of the other gases of importance are the most prominent, 79% nitrogen and just 0.03% is CO2 or carbon dioxide. There's also argon and some other smaller amounts of trace gases, but these are the ones that are always the most important for what we're kind of talking about now. So just keep that in mind as we go through this. You have to have the right air starting out. And so let's get into our airways because any talk about the respiratory system has to always start with the airways. And remember, A for airway, because that's going to play out as you learn your assessment skills. So let's start about where we're going to be bringing air in. The nasal passages and the mouth are the two areas where we're going to be bringing air in. And remember, when we're talking about pathophysiology of the respiratory system, when we talk about airways, our biggest thought process is it open or is it blocked? And we always think through that lens. Now remember, we are going to divide our airways into the upper airways and the lower. When we talk about the upper airways, first and foremost, we're going to be talking about things like the nasal pharynx, which is the entire nasal passage all the way back into the back of the throat, or as we'll call it, the oral pharynx. It's got some responsibilities. It's not just for tubes to breathe the air in. It also heats and moistens the air a little bit. By doing this, it makes the air a lot more conducive to getting down into the lungs. It also filters a little bit. That's what your nose hair is for. And so any type of a blockage in the nasal pharynx could become problematic, especially for infants or very young children who tend to be more what we call obligate nose breathers. In fact, when you're born, you do not even know how to breathe through your mouth. So all infants and neonates, which are babies that are just born, are obligate nose breathers. We have got to make sure their nasal passages are clear, or else we're going to end up on the blocked end of our question about the airway. Going down from there, still in the upper airways, we have the oral pharynx. That oral pharynx sits right back here. Excuse me. The back of the throat is where we tend to find one of the biggest blocked situations that we deal with the airways, and that's when the tongue gets in the way. If you have somebody who has lost consciousness, they are laying flat on their back, that tongue becomes problematic. The upper airways come all the way down to the area that has the epiglottis, which is right here, and also the pieces of the larynx, which extend down to where the trachea starts. Obvious problems there could be choking on food, You could have issues with swelling in that area from burns. You could have issues with swelling from infection. There's a whole host of things that could cause some issues as far as a blocked airway at this level. One of the biggest sounds that we hear from people who have a blockage at this level is a sound called stridor, which we'll get to more when we get to the airway and respiratory chapters. But just be aware, the two biggest sounds you'll hear from any blockage of the upper airways are going to be stridor, snoring, and I'll also put gurgling into that as well, because obviously any type of fluid that is sitting in that area when somebody's trying to breathe could become problematic as well, and we'll get gurgling with that. Get this off the board here, and we'll move down to the lower airways. It's got to be an easier way. I'll figure it out. And so when we talk about the lower airways, we're talking about everything from the larynx down. So anything from the larynx down. The trachea is that long, rigid tube that brings air from the upper airways down into the lungs or the lower airways. This tube has rings on it to keep its structure. It's kind of easier to look at from the back. You can kind of see how, as the trachea comes to the bottom, you have a split off of what we call the main bronchi. You have a right main bronchi and a left main bronchi. The carina is this area here in the middle that splits off for the two. You'll notice that they do not split off equally. One is a bit lower in terms of how it comes off than the other. This is problematic for us sometimes when we place an airway into the trachea, something like an endotracheal tube. If we do go down a bit too far as paramedics when we place that tube, we run into issues sometimes with that tube actually making its way into the right main stem. When the tip of that tube sits here, you can guess where the problem is. As we pass air down through that tube that we've placed with the bag valve mask, that air is only going to go into one lung and not the other. And so we recognize that by listening to the lungs with the stethoscope after we place a tube. If we do notice that, we just back the tube out a little bit and then listen to our equal breath sounds. The lungs, they are not created equally. They are different sized. If you look at the lobes of the lungs, which are divided up here by these kind of lines here, you'll notice that the left lung has 2 lobes, but the right lung has how many? 3. The reason has nothing to do with the air intake, because they both do a fine job. The reason is because of the space that's needed to put something right here. And I think most of you know what that structure is. That's where the heart sits. And so that's why you get this difference in terms of the size of the lungs. The lung tissue itself is spongy. It is not where you get the gas exchange. The gas exchange, remember, takes place in the alveoli only. And so as we dissect through this lung tissue, you got to remember that all of the different structures play a part in getting that air where it needs to go. While we're talking about the lungs, I want to bring up that sac that surrounds the lungs. We talked a little bit about this. Let me get back to that. Apologize. That sac is called the pleura. Now, that sac is designed to have 2 layers to it with a small amount of fluid that keeps the lung tissue from sticking to the sides of the thoracic cavity. That sac has to be intact in order for you to have good mechanical breathing. If there is any protrusion into that sac, whether it's from trauma or whether it's from a blowout of sorts through the lung tissue itself, this sac can fill with air or blood. And if that happens, there's nowhere for the lung tissue to go except for collapsing. And so that's when you start to get that collapsed lung situation, is when this sac gets either blood or air accumulating in it. Remember, the two parts to this sac are the visceral pleura and the parietal pleura. Visceral is always going to be the part of the sac that actually touches the organ surface. The parietal is the outer part of that sac. And that fluid that's inside of there is designed to keep those two parts from actually sticking together. As we take away parts, let's get down to the structures inside. So we'll remove the tissue itself and we'll take a peek at what we have going on inside here. These structures here are the bronchioles. These bronchioles are a tree-like network that run through the entirety of the lung. There's a lot more of them at the lower part of the lung, which we call the base, and a lot less at the upper part of the lung, which we call the apex. These bronchioles are the tubes in which air passes through, making its way to the alveoli, which sit right at the tips of these bronchioles. You can't see them because they're so small that we'll actually have to go to another part of the anatomy lesson here in order to see them. And remember, we have millions of them. That's where the actual O2 needs to get to that you inhale, and that's where the CO2 needs to get to from the circulatory system to make its way out and then back up through. Now, if you notice these bronchioles, they kind of have a stripe to them. These stripes here are the smooth muscle parts. That smooth muscle constricts or relaxes, and what it does is it either constricts or dilates the bronchioles themselves. Whenever you want to take deeper breaths in, say, from being in a fight or flight scenario, the smooth muscle will relax because your sympathetic nervous system had kicked in, triggering it, and you'll be able to take in deeper breaths because the bronchioles themselves, the diameter of them becomes more dilated. This is a problem for asthma patients. We'll get to that a lot more in that chapter, but you can kind of put two and two together. If this smooth muscle constricts, we run into problems with the constriction of the bronchioles. Makes air harder to get in and out, especially out. Some of the lower sounds, as far as the possible obstructions of the lower airways, are wheezes, which we just discussed. That's when you get that constriction of the bronchioles. Rhonchi is a sound that you can hear when you have phlegm or mucus developing inside of the bronchioles. We've all had that nagging kind of cough that's productive, or you're bringing up junk, that kind of rattly sound when you breathe. You can kind of hear me a little bit right now. I kind of have some of this. That sound is called rhonchi, and that's the sound of air passing over top of fluid as it goes through the bronchioles. The third sound that we run into in terms of obstruction is crackles. Now, this takes place more at the alveoli layer or level, and that sound is the closing and opening of the alveoli because of fluid being around or inside of the alveoli. Sounds kind of like Rice Krispies, and that's why they call it crackles. An older term for it was rhonchi. Rhonchi. Now, if you were to zero all the way in to see what these alveoli look like, this is what you're going to find. At the termination of the bronchioles, you'll find the alveoli sacs. There are millions of these sacs, and their only job is for gas exchange. Remember, we've got oxygen coming in, and we've got CO2 going out. And so the circulatory system will bring deoxygenated blood that will wrap all throughout this whole network of alveoli, dropping off carbon dioxide and picking up the fresh oxygen that's coming down the tubes. The tubes are the bronchioles. You can see the smooth muscle a lot better in this depiction here. That smooth muscle is what's going to constrict or relax and dilate these bronchioles. You can also see the alveoli a lot better, and you can kind of see, let's see if we can kind of take a couple of them out. You can see the network goes on even on the inside of there, where you get the capillary beds that come in and do the gas exchange. Now, as far as how this system works, remember, breathing is an autonomic process, which means the autonomic nervous system is who's responsible to make sure breathing is happening and continues. It also decides when to breathe faster, when to breathe slower. And remember the two parts of that autonomic nervous system, because this is important to understand when you talk about hypoperfusion or that shock state. The two parts of the sympathetic nervous system are the two parts of the autonomic nervous system are the sympathetic and the parasympathetic. Remember, when the sympathetic nervous system takes over, everything increases. Heart rate, your breathing, ventilatory rate, you get your pupils dilate, you go into that mode of fight or flight, which is going to increase everything. When the parasympathetic system takes over, you get everything dropping, that decrease in heart rate, that decrease in respiratory rate. It's back into more of the relaxed version of living. And we want to stay, for the most part, in the parasympathetic. When the sympathetic system activates, that generally means there's a problem. It can be a perceived problem or a real problem, as if perfusion was not being met. The sympathetic system comes in and tells this respiratory system what to do through the spinal cord and also the cranial nerves. These strands that you see depicted here are coming down the spinal cord and leading to certain parts of the cervical vertebrae, which we'll learn about, where these nerves actually come out of and come in and tell the diaphragm to work, come in and tell the heart rate to beat faster, come in and tell the intercostal muscles of the lungs to actually breathe with the diaphragm with the work of breathing. All of the muscular things that need to happen, all of the things you cannot control that need to happen, all come from stimulus from the brain, either the sympathetic stimulus or the parasympathetic stimulus. The vagus nerve or the vagal nerve comes in and actually innervates not from the spinal cord, but right from the cranial nerve itself. So it comes right from the brain. Once this is all put together, the last part of this is understanding the mechanics of how breathing happens. And so we know that when we combine a few things, and give me a second here and we'll make a quick kind of note of it. We're going to combine the brain. That's not a good color there. We're going to combine the brain telling the respiratory system what to do with the diaphragm, the intercostal muscles, and together we're going to get inspiration and expiration. Now remember, in a normal person who is healthy, only inspiration requires energy. Inspiration is the only active part of this. Expiration is supposed to be passive, which means no energy is required. And in order to take a breath in and to take a breath out, everything has got to be functioning well to do this without making the passive part become, without making the expiratory part become active as well. And so, as you can see here with our depiction, in order for mechanical ventilation to take place, on inhalation, the diaphragm drops down, the intercostal muscles pull the chest cavity outward. When that happens, what type of pressure is created inside of the chest cavity? Negative pressure. Remember, negative pressure inside the chest cavity. Air rushes in. Gas exchange takes place at the alveoli. The diaphragm then relaxes and comes back up. The intercostal muscles relax, chest comes back down, creates positive pressure, which then forces the air out of the body. Passive, as long as there are no issues with any type of obstructions. And so everything we've just looked at is through the lens of the A and the B in that ABC trio of letters that we know must be supported at all costs. The airway must be open, both the upper and the lower. The breathing must be functioning and adequate. And remember, in terms of adequate versus inadequate, we need to look through that lens of two different things. In order to say that our breathing is adequate, we must have a good respiratory rate and good tidal volume, or the amount of air coming in. If we do not have a good tidal volume and a respiratory rate that's not crazy high or low, we cannot deem it to be adequate. Both of these things together must be good. If you're missing one of these to the extreme, you have inadequate breathing, and we must assist with a bag valve mask. That's it for our respiratory talk here. We'll get some cardiovascular system stuff going here shortly. I hope this helped. Any questions, anytime, reach out. We got you.